little bit about me. We started this group for high desert professional counselors to sort of give a voice and put some visual presence on the professionals here in the high desert. I believe we have very good providers up here. You know that it's hard to get a psychiatrist up here. It's hard to get good help up here. And so typically the community up here has to travel all the way down the hill to get help. But I want to change that, and that's the mission of the High Desert Professional Counselors Group, is to really change that and to keep patients and clients right up here in the high desert, and to sort of shed the light on the quality people that we have up here that could meet their needs, all right? So without any further ado, I'm gonna turn it over to Jim. Jim and I are gonna tag team on this, and I'm gonna let him get started. He'll tell you a little bit about himself. If you got any questions, just let me know, all right?
Hi, good morning. I just came in from the street. I heard there was free food, so next thing I know, I'm up here. I had the pleasure last year of working with Dr. Wilson at the APS MDT. We presented on personality disorders and the aging process, so we're going to incorporate that into the presentation today, not only personality disorders, but how they're affected by the aging process. I have an MSW, LCSW, number of years of experience in the social service field. Went to LSU for my MSW. Laura Ramos is also involved with the LSU Fighting Tigers. And I worked in Louisiana at a emotion disturbed boys home and worked with them with Child Protective Services in Baton Rouge, and also out here in San Bernardino County. In San Bernardino County, also was a supervisor for Department of Aging and Adult Services. I worked APS cases, and then later went into behavioral health. I worked behavioral health for 7 years. Went to home health and hospice. I had been working part-time for several years, and I went full-time for about 1.5 years, and then went with Victor Community Support Services for a year as a supervisor in Barstow, and then later went to the U.S. Marine Corps base where I met Dr. Wilson. I originally went in as a Civilian Employee Assistance Program Coordinator, transferred over to the Family Advocacy Program after they said my job was illegal, after I'd been there for 9 months, and fortunately was able to get into the other side, the other base, and I worked community counseling program, and then later became behavioral health section head, which I've been for the last 3 years. And one accomplishment that I'm proud of with that is we had a major inspection by headquarters, Marine Base from Quantico, Virginia in 2018, and we passed, so I was very, very fortunate and very happy about that. Anyway, one of the things about personality disorders, it's a very exciting topic because personality disorders seem like they're from another world. They seem like they're from another planet, but they basically have the same traits as we all do. They are human, and if you look at personality disorders, you might see different traits that you can relate to. And the thing is about these traits, I mean, like I say, they're human traits, but if you look at the bell-shaped curve, I meant to bring a paper today, but if you can imagine a bell-shaped curve, and that most personality traits are within maybe an 85, 90% percentile, but the extremes on each side are the personality disorders, and those include flexibility, inflexibility, openness, guardedness, suspiciousness, sociability, different things that are traits that we all have, but the personality disorder traits are become inflexible, rigid, they're stable over time. It's hard for them to adjust to new situations because they have the same coping skills because those are their core beliefs. So personality is a combination of thoughts and emotions and behaviors that make you unique. And basically we're born with a certain genetic components from our parents and from our grandparents and on down the line that may affect our temperaments. People are born with different temperaments. They may be born with very anxious or calm, if you're blessed as a parent with a calm baby. Also, even aggressiveness may be a trait that people are born with, as well as the ability to socialize with others and kind of curiosity and exploring versus inhibition and excitation or introvert, extrovert type of tendencies that people are born with. And then how that interacts with the world, with the environment around them, how their parents react to that, especially if people are born in situations, maybe it's chaos. I think everybody's heard of the ACE studies, where children who are born in families where there's substance abuse, mental disorders, child abuse, if there's domestic violence, there's a number of different factors that if children are born into that situation and they interact with their environment, then they develop, later on in life, they're much more likely to develop mental disorders and even physical health disorders, because they're more likely to rely on coping skills that include substance abuse, alcohol, drugs, because in their environment that they grew up in, they don't learn coping skills that are healthy. They learn inappropriate coping skills. So that can lead to physical, medical problems, as well as mental health issues, including personality disorders. So personality disorders can significantly disrupt the lives of both the affected people who care about that person and the person themselves. So in order to have a personality disorder, a person has to meet 2 of 4 criteria. One, their cognitive abilities are distorted. They have distorted thinking patterns. Their emotions of their ability, the range of emotions, the intensity of emotions, it can be an impairment. Their ability to socialize with other people is impaired, and the impulsivity of that person. So they have to meet 2 of those 4 criteria. And it has to cause distress or impairment. So 2 of those 4 have to be impaired. But the distress that they cause is not necessarily internally, because they believe that's who they are. They really distress the rest of us. And they say that about 15% of the population has personality disorders, but they comprise a large section of the court system, legal system, even social service system. I know when I was working Child Protective Services, at one point I had a caseload of 40 kids, and 3 of those kids were conduct disorder kids, and they took up 50% of my time because it was always, putting out fires. So even though they only make up 15% of the population, they create enough disturbances and issues where it causes the authorities to get involved a lot more than 15% of the time. So what are healthy personalities? If we're thinking of distorted thinking, if we're thinking of people with personality disorders that have impairments, what exactly are healthy people? So people who are flexible, people who can meet challenges in situations, they can adapt to situations. These are healthy personality traits. They're balanced, resilient. They're able to, when new things come up, maybe their car breaks down, it may be disappointing, they may feel bad, but they're able to rearrange resources, rearrange their time to the point where they can meet whatever challenge comes up. They also have empathy and compassion. They can understand other people. When other people are down, when other people are having problems, they can empathize with them, which I think is one of the primary problems with people with personality disorders, is they don't have the ability to have that empathy or compassion toward other people. They're so self-absorbed in themselves or the things around them that it's very difficult for them to be able to understand how other people feel and how, what happens with other people. So also the sense of self-respect. People who are healthy, they have a kind of a give and take. Not everything's going to go their way, but they're able to kind of think positive and basically get through situations. And they also have respect for other people, whereas people with personality disorders have a difficult time with that. So again, personality disorders is a very rigid, and it has to be stable over a period of time. So it's usually seen in adolescence and early adulthood. Children can be diagnosed with a personality disorder if it's something that is very inflexible and something that is pretty serious personality disorder, but it has to be at least 1 year in duration before you can diagnose a child with a personality disorder. But there's one personality disorder that can't be diagnosed before 18. Does anybody know which one that is? Antisocial. Yeah, antisocial. But they have to have had symptoms or meet the criteria for conduct disorder before being diagnosed with antisocial personality disorder. So there are many types of personality disorders, and they have 3 clusters that, you know, the wisdom of the DSM have put in several clusters. I don't really understand completely because even though cluster A is odd and eccentric, paranoid personality disorder just doesn't seem to fit with schizoid and schizotypal, although they can, all 3 of them can have probably more likely to have psychotic episodes than the other ones, but all personality disorders can have brief psychotic episodes. And it's not necessary for an individual to exhibit all the signs and symptoms in order to be diagnosed. So if someone has some really pronounced symptoms that you know, define a personality disorder, essential features of a personality disorder, they may not meet every criteria, but they can still be diagnosed. Any questions so far? How's the breakfast? Good, good. All right. So cluster A is characterized by odd, eccentric thinking or behavior, include the paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. And if you think of cluster A, you can think of the A as an alien, basically because these are people that do seem like they come from a different planet and don't seem to fit in. First one is paranoid personality disorder. These people are very suspicious and distrustful of other people because they automatically assume that people are trying to deceive them, trying to exploit them, they're trying to get over on them. These are people that basically, if you think about it, they would be very healthy thinking if everybody was antisocial personality disorder. That's what they view the world. Everybody's antisocial personality disorder, and so they're not going to get taken advantage of. They automatically assume you're antisocial personality disorder, and so they may react or they may act in self-defense even though you haven't done anything because they know you're trying to do something. They know you're trying to get over on them. They have unjustified suspicion of the loyalty or trustworthiness of other people. And of course, they're hesitant to confide in other people because they think whatever they say is going to be used against them. So are these people likely to come into therapy? No, definitely not. Not unless they're being forced into, maybe by a spouse, into marriage counseling, or most likely by the court system because they've done something that got them into trouble. They perceive innocent remarks or non-threatening situations as personal insults or attacks. So if somebody says, "Hey Joe, you did a good job yesterday," Joe, if he's paranoid personality disorder, is automatically thinking, what's this guy's agenda? Why is he telling me that? What's he want from me? Is he going to ask me for something later? Or he doesn't think I do a good job every day? You know, so he's automatically thinking something's wrong when that guy, even if compliments. And they have angry or hostile reaction to perceived slights or insults. So these people are more likely to do the road rage. If you cut them off, or if you don't let them in, you know, they feel like it's a personal insult. You're dissing on them, you're disrespecting them. So they want to get even. So these people not only have a tendency to hold grudges, they're revengeful. They're thinking all the time how to get back at people because they perceive people have done insults or something to them that, you know, the other people haven't, you know, they were innocent remark and didn't mean it that way. And they have unjustified recurrent suspicion that a spouse or sexual partner is unfaithful. So how likely is it that these people are going to be involved with domestic violence, right? So who would want to be in a relationship with a paranoid personality disorder or stay in a relationship with someone? And the only people I could think of may be a dependent personality disorder. But these people can be dangerous. We all know that antisocial personality disorder people are dangerous and can be thugs and can be serial killers, can be murderers. But these people are more likely to be workplace violence or domestic violence or to explode on people. Schizoid and schizotypal are more withdrawn. They don't really want to hurt anybody. They just want everybody to leave them alone. But these people, like I say, they automatically think somebody's trying to get over on them, so they're going to get back. They're going to act out. So their cognitions is better get him before he gets me. Don't get mad, get even. And they believe in conspiracy theories because they believe the world is against them. So they feel like anything comes up, it's really other people trying to plot against them. So again, they're more likely to do workplace violence because they're thinking everybody's out to get them. They're guarded, suspicious. They can become fanatics. They can, get involved in cults. They can get involved in groups. You might think of skinheads. It's kind of like instead of me against the world, it's us against them. So they join other people that are like-minded and just confirms their suspicions about the other people. And so the therapist better have a good insurance policy when you're dealing with paranoid personality disorder because they like to go to court. They take a lot of people to court. I know someone who, a friend of mine used to go hiking with all the time. I mean, this guy's got lawsuits in every state, I think. He's got lawsuits against a number of different car companies, state of Arizona, trailer park in Washington, different things. So my wife keeps telling me, be careful, he's going to sue us at some point. So here's a little cartoon. Don't you look nice this evening? So that's your little game. So they're automatically thinking that whatever the person says, it has to be some kind of malevolent intention behind it. So we don't know the history of this person. Maybe she has reason to think that way. And I just like this cartoon, so I threw it in. But it makes you think. So sometimes paranoia can be a healthy thing. Sometimes it can be justified. There's times when we have to be careful not to overdiagnose someone with a paranoid personality disorder just because they may be suspicious of us, distrustful of us. Maybe they're distrustful of authorities. People who come into the country, maybe immigration process, maybe they don't have a firm hold on the language. They may be scared, afraid of authorities. They may distrust authorities because of something that happened to them. So just because a person may come across as having paranoia with us doesn't mean that they're a paranoid personality disorder. It crosses a bunch of different spheres in their life. So these are people not only that are going to be distrustful, suspicious, maybe hostile toward authority, but they're also going to be suspicious and distrustful of their spouses, their family, their friends. So it crosses the whole spectrum. So in order to make this diagnosis, you want to make sure probably third-party collateral or really firm history or over time how this person deals or works with different people, not just one group of people. So then we go to schizoid personality disorder. And these are people, like I said, they just want to be left alone. They're not out for revenge. They're not out for hurting anybody. They just prefer to be alone. They have a limited range of emotional expression. It's hard for them to feel pleasure in any situation. Most of us might feel pleasure walking hand in hand with somebody or walking along the beach or going to the mountains. Something that we may feel in the moment and feel pleasure. But these people are very limited in their ability to feel pleasure. And also, it's hard for them to pick up on normal social cues. In fact, there's some discussion about whether schizoid personality disorder is actually in the realm of autism, because there's a lot of similarities in that as far as dealing with other people, their range of emotions, the withdrawal. They appear cold and indifferent to other people. They have little or no interest in having sex with another person. Doesn't mean they don't have sex, but not just with people. But probably that's why they like to stay alone. So common defense mechanisms of schizoid, they use intellectualization. In other words, they have very little emotions. And so everything has to be intellectualized. And it kind of puts a distance between them and other people. It's hard for them to have social relationships with people. They're much more comfortable with machines, with computers, technology. They're more likely to withdraw. Like if somebody slights them or criticizes them, they're not going to act out. They're not going to get back at the person. They're going to withdraw. And it's almost like their drug of choice is fantasy, a schizoid fantasy. So they might use drugs or at times to enhance their fantasies, but basically that's their first line of defense, is they withdraw when something happens. The schizoid personality disorder, serves safe, you might think of it. It might help to think of some of their characteristics, solitary lifestyle. They're indifferent to praise or criticism. So it must be very difficult for bullies who criticize them or people who criticize them, because they don't care. You can compliment them, you can tell them really nice things about them, or you can tell them bad things about them. It doesn't matter. It just kind of blows off. They don't really have interest in sexual experiences. They don't enjoy activities. They lack friends, but don't feel sorry for them because they don't want friends. And they come across cold and detached. So this is, you could say it's a schizoid meeting where everybody's looking at their cell phones. Also a cultural thing nowadays, so it's not necessarily schizoid, but it's just an illustration that when people who have schizoid personality disorder, they don't want to socialize, they don't want to communicate with other people. So the schizotypal personality disorder. These are people with peculiar dress, thinking, beliefs, speech, or behavior. And they also have odd perceptual experiences. They may hear their name being called out. They may be hearing voices, flat emotion, inappropriate emotional responses. It's not that they don't necessarily want to have friendships or want to socialize with other people, but they feel very uncomfortable around other people. They also can have suspicious response to others. If they go to a party, most people go to a party, if you don't know a lot of the people there, you may feel uncomfortable in the beginning, but usually people kind of warm up and start feeling comfortable later on. Whereas schizotypal, they actually start feeling more uncomfortable as the evening goes on, because they start having some paranoid thoughts. And so it's more likely that, that they'll feel more uncomfortable and leave. They also have this magical thinking. They believe they can influence people through their thoughts. Basically that they can either somewhat influence or control other people by the way they think. They may be more likely to think about aliens from other planets and maybe voodoo or some type of magic that they can have over other people. And they believe that certain casual incidents or events have hidden messages meant only for them. Basically, something comes on the radio, a song comes on the radio, or something comes on the loudspeaker, and they think it applies to them, even though obviously it doesn't. But it may even help them make a decision or make them feel that it may make have meaning to them that it wouldn't have meaning for other people. So some of the common defenses, same as schizoid, they kind of withdraw into fantasy. Again, they're not bad people. They don't want to hurt anybody. They just want to be left alone most of the time. And they don't fit in. If you remember the TV show Seinfeld, Kramer, awkward mannerisms, very eccentric. He typified someone with schizotypal personality disorder. Also, I put down GG. I had a client when I was working with the Department of Behavioral Health, and this guy, I'll call him Glenn. He lived out in the middle of nowhere, lived in a little trailer in the middle of the desert, no running water, no electricity. I'd pick him up once a month. I'd bring him into the office for a doctor's appointment, and then I'd take him shopping and then take him back. And he would come in, you know, his clothes would be all crumpled up and different buttons down here, and shirt tail hanging down, and hair. He had thick black hair everywhere, you know. And but the psychiatrist later told me that this guy Glenn, he said, you know what, he's the happiest client I have. He's really, you know, he enjoyed living in the desert. You'd think he was a desert rat. I guess he had become a desert rat, but he later confided in me that he had come from LA, and he had lived in environments that were very dangerous and situations, so he felt much more comfortable living out in the desert. And overall, seemed to be a very happy person, one of these people that pushes the boundaries of independence. He had diabetes. He didn't have electricity. He had to go to a neighbor's over a mile away. They agreed to keep his insulin in a refrigerator. But he lived the way he wanted. He lived very independently. And unfortunately, a couple of years ago, he was hiking out in the desert and actually fell into a ditch, broke his hip, and there was nobody around, so he ended up dying. So schizotypal personality disorder, you can think of it, a UFO aider, unusual perceptions, friendliness except for family, odd beliefs, thinking and speech, affect is inappropriate and constricted. They have ideas of reference, not delusions of reference, but ideas of reference. And they doubt others, they become suspicious too, eccentric in appearance and behavior, and reluctant in social situations and anxious. Again, this guy Glenn, who that I would see, I talked him into coming to a group that I had at Behavioral Health, and this was a group I had people with schizophrenia, bipolar disorder, major depressive disorder, with psychosis. I mean, it was an interesting group of people. And Gary was able to come once a week, and you know, he seemed to enjoy it at some point, but he had no social skills whatsoever. And he didn't say things sexually inappropriate, but just things would come out that, you know, didn't make sense or made sense to him, I guess. But people with schizotypal personality disorder, they may say things like, I was very talkable today. You know, so it's kind of makes sense, right? But not completely. It doesn't really gel, doesn't really fit in totally. The schizotypal personality disorder, actually in the DSM-5, is now listed in 2 sections. It's not only under personality disorders, but it's also under the schizophrenia spectrum and other psychotic disorders. So also, I just want to let you be aware that in the DSM-5, there's a section 3 that talks about future disorders or how they may classify in the future, kind of getting ready eventually for a DSM-6. And they talk about personality disorders. In fact, I thought they were going to change personality disorders for DSM-5, but pretty much kept it the same. But there's a lot of talk about different dimensions and different ways of looking at personality disorders. So I looked over at section 3 in the DSM-5, and what they look at are things like identity, self-direction, empathy, and intimacy as far as what comprises a personality disorder. And they basically reduced the number of personality disorders from 10 to 7. And for some reason, they leave out schizoid, paranoid, and dependent personality disorder in that discussion. So the aging process for the cluster A, generally they get worse, and you can imagine, you know, you can understand why, because they isolate themselves, they don't trust people, they don't trust the medical system. Can you imagine a paranoid personality disorder going to a doctor or a hospital? You know, they feel like they're being poisoned or something is going to happen to them. And people with schizoid and schizotypal, they just want to be left alone. So, they're much more reluctant to go to treatment, and if they do get treatment, they're resistant in the treatment. They may not follow, the recommendations. And they have lack of resources. They don't reach out for help. With some interns that I meet with, I've talked to them about eco maps and how in adult protective services, when people would come in for services or we would go out to their homes, we would diagram, the different systems in the environment, and most of them had very few connections with family members, friends, or a medical system, or different formal support systems, like support groups or whatever. And so one of the things we would look at is how many connections we could connect people to. So people with schizoid and schizotypal have very few, and paranoid have very few connections with other entities, other people. So reaching out for medical treatment and, of course, psychiatric treatment is very difficult for them. And so they delay medical treatment, resistant, and have increased perceptual issues. I think a lot has to do with their solitary lifestyles, and they don't have much socialization with other people. So of course, it's more likely they may develop perceptual issues, hallucinations, voices, things like that, because they don't have the contact with other people. Okay, so I'm going to turn it over to Dr. Wilson.
Well, that concludes our presentation for today. So, Linda, very good to see you. Dr. Lincourt, very good to see you. Tina. And I'm going to just pick up and just keep rolling here is what I'll do. Talking about cluster B, personality disorders are typically characterized by overly emotional and unpredictable thinking and or behavior. And those include, of course, Jim touched on a little bit, antisocial personalities, borderline BPD, and narcissistic personality. And these are some of the ones that I come in contact a lot with, I think, because we've learned to use these labels as weapons, particularly spouses, significant others do. I come in, I don't know how many times a day I hear, my husband is narcissistic, or, or my wife is borderline personality disorder. And although we know that there are a lot of these diagnoses that are present within our society, not everybody you come in contact with is narcissistic or borderline. It could be you. No. So I like this cartoon here. So the anti-social personality, some of those characteristics include the need to persistent lying, stealing, conning others, disregard for other feelings, aggressive behavior, impulsive behavior, and a lack of remorse for their behavior, the antisocial personality. And here are some of the common schemas. Rules are for fools when it comes to these guys. If others are hurt or offended or injured by their behavior, it's their fault for believing in me. See that a whole lot, especially when we talk about young men. I think, at least in my experience, I will do whatever it takes to get what I want, and empathy is for the weak. You guys familiar with this? So lack of empathy, like I said, regard for others, hostile toward others, usually don't think about the consequences of their behavior, and prone to criminal activity. So here's sort of an acronym that you can think of when you're trying to diagnose or determine if somebody has this particular personality disorder. Conduct disorder, typically by the age of 15. Antisocial acts, larceny, a lack of superego, unstable safety of self and others is ignored, very high risk. Again, that impulsive behavior that you'll see. Money is a problem. Aggressive, typically violence in the sense of attacking other people, very, very aggressive in behavior, all right? Domestic violence not occurring exclusively during the, Jim talked about this, how the schizophrenia, I think the schizophrenia, let me talk about this real quick. I think I see this a lot in bipolar patients. Anybody see that in bipolar patients? They almost look as if they have a personality disorder, right? Yeah. So when they're in that mania phase there, I'll let my consequences be my guide. My conscience, I'm sorry, be my guide. And it turned out to be a sociopath. So BPD, another really big one I think we see a whole lot. We say in this particular field, females have a higher number for BPD. Any guesses why you think females have a higher rate for being diagnosed as BPD? Anybody?
I'm just wondering if it has anything to do with relationship and bonding, because for women, for females, relationships are priorities, and one of the difficulties for a BPP person is to form relationships.
Absolutely, very top of the list. Yeah. I don't doubt that at all. I think another one of the reasons why we see such a higher number for females with this particular diagnosis is because females will come and get help a lot faster than men will come and get help. Where men typically will, not show up at our office or in our clinics, you will find females doing that. And you're absolutely right. One of those top criteria for meeting this particular diagnosis is we look at relationships, because relationships, again, I believe are so very important. Yes, ma'am.
That's why I think that the dialectical behavioral therapy approach is successful, because Marshall Linehan recognized that relationships and the importance of bonding, attachment, were part of the healing, and amazingly, from what I've read, it was effective.
DBT, dialectical behavior therapy, absolutely. And we often say, this is another one of those particular personality disorders that it's not if you get sued, but if you treat BPD, it's when you get sued. So again, not if you get sued, but when you get sued, when you deal with BPD. One of the things that, one of the most effective ways in treating, I had a group in St. Louis, and typically one-on-one, we don't do real well unless, this is what you've been doing for years and you have an evidence-based approach to it. One-on-one typically doesn't work very well with BPD. You need a group is what you need, and that group modality is DBT. I've watched where those particular individuals are able to check and say things to each other, call them out, where we couldn't do that as providers. We could not do that. But them themselves, they could do that. One particular individual, I remember, she was a frequent ER visit for suicidal attempts, and one-on-one just did not work with her. We put her into a DBT group, and it took a while. To get some progress, but man, she really, I did the DBT group, and one of the things I love is I didn't have to work. I just showed up and sort of facilitated, and man, the way they checked each other, called each other out, and talked about how, you've got to deal with this problem. This is not everybody else's problem. It was just phenomenal to see how DBT, that particular modality works when you're dealing with the BPD personality. So absolutely right. There is, of course, intense fear of being alone or abandoned. One of those criteria that we see and we look for when we're talking about the BPD. Intense display of anger. I love you, I hate you. Please don't leave me, get out of my face. I never want to see you again, right? And then stress-related paranoia that comes and goes. And again, this is one of those diagnoses I think you see a lot of the same criteria for bipolar, especially when they're experiencing a mania phase. Any questions? Unless anybody from San Bernardino office has any questions, I'll take them. I got my thing up here where those guys can ask me questions here. If they have questions down there, I should say up there. So some of the common defense mechanisms: splitting, both harmful and helpful impulses are split off, frequent projecting onto someone else. The defended individual segregates experiences into all good or bad, that bipolar thinking. And again, this is where DBT comes in, because one of the things we really try to do with this particular approach, and I know Jim's going to talk about some of the treatment that you can use for personality disorders, but BPD, we really try to help people to understand that life is really not black or white. There's a whole lot of gray, and when you learn to live in that gray, you really reduce that stress and the anxiety that comes along with this particular diagnosis. So helping people to be okay with not being okay. Like, no one ever died from not being okay, all right? Although it's a very strong and intense emotion, but we try to help them get rid of that sort of all or nothing thinking. When splitting is combined with projecting the undesirable qualities that one unconsciously perceives oneself as possessing, one's consciously attributes to another. Projection identification, the object of projection invokes in that person a version of the thoughts, feelings, and behaviors projected. All right? Any questions? So common schemas for the BPD: I'm not sure who I am. I will eventually be abandoned. They like to they sabotage relationships a lot. They end them typically, just because they already have in their mind that it's going to end anyway. So they might as well, preemptive strike, not to be hurt, and so they'll go ahead and self-sabotage. All right. My suffering is so great I can't stand it, and that's again helping them to be okay with not being okay, because when they experience this, that polarized thinking is that life is, you can talk about a relationship ending and their life is over with. Again, some of that reasoning is how important relationships are, particularly to the higher number gender, which is females in this particular category. When a relationship ends, life is over with. To say no, any distress actually is so damaging that they just lose all sight. All right, whenever there's some kind of distress like that. My feelings control me. I am so very lucky to have someone as good as he is. I'm sorry, that's gender fine. He is in my life. I am very unfortunate to have met such a despicable person. When I am overwhelmed, I must escape. And one of the things I try to do when treating this particular diagnosis, this particular person who has this diagnosis, is really helping them see that people are not good or bad, but really they can be good and bad at the same time. And this is that great thinking that we try to introduce people to, all right? Because you'll have bad people do good stuff all the time, and you'll have good people do bad stuff all the time. So here's where we get a chance to challenge that irrational thought that people are either or. Any questions, comments? Jim, somebody says, Olivia said hi. Don says hi. Borderline personality disorder. Here's an acronym we use here. I raise the pain for I. Identity disturbance, not really knowing who they are, having a difficult time identifying themselves. Relationships are unstable. R. A, abandonment, always, thinking that, they're going to be abandoned, always expecting that to happen. Impulsivity. Suicidal gestures are very high among this particular diagnosis. Suicidal attempts and suicidal ideation. And that's the reason why hospitalizations are so high among this particular group of people. And again, that's where the reason why DBT comes in so handy. Most mental health institutions, outpatient, IOP, PHPs, inpatient, intensive outpatient programs, and partial hospital programs, they all use the evidence-based standard is DBT across the board. Emptiness, dissociative symptoms, affective instability, paranoid ideation, anger, poorly controlled, idealization, and followed by devaluation and sort of a negative, just a negative self-defeating thought about themselves, low self-esteem, their self-worth is very, very, very poor. And I have a particular, we say that last year when we did this presentation, Jim, we did it particularly geared toward aging adults. And I have one particular case where an aging lady diagnosed with this particular diagnosis. I was hoping that over the years, and I told the family that we should see some improvement, you know, as they get older. But I'm starting to question that now. You know, I'm starting to question that a little bit. If we see these symptomologies really improve, typically we think that as you get older, the brain processes sort of slow down. There is the avoidant personality disorder and the antisocial personality. There is some evidence that does show that those particular personalities, they do get better as they get older.
Why do you think that there isn't an improvement with DBT as someone ages? What conclusions have you
Have I come to?
Yeah.
I've not. So this particular case here, I've not seen as. So one of the things I look for as a provider, I can tell when you've done this for a while, you can just sort of pick up on characteristics when a patient first presents to your office, if there's a possibility of this. And some of the things that I look for, and I'm not saying this is true for everybody, so this is where you have to make the educated guess and then rule out if it is or if it isn't. But some of the stuff I look for is the over makeup, strong, lots of makeup, the very flamboyant presentation of a person. And I was thinking that, you know, that would sort of decrease, and the sort of I love you, I hate you relationship would decrease. In this particular patient, though, it doesn't seem to be decreasing, though. And I think it's what it is that if it was just BPD, I think we would see improvement, but the problem is it's not just BPD. There's a comorbid disorder, which is, I believe, is not allowing the improvement that we would typically see as you age with this disorder. And so because there is this comorbid disorder, I'm not seeing that increase or that improvement, I should say.
You would think that with a decrease in hormonal...
Exactly. That's what, and I think that's typically what we would see. Would
Right.
be them sort of balancing out is what it was. But I think when there is a comorbid disorder, there's a less likely chance that you'll see that completely, you know, go away. You know. So, any other questions? Talking about the BPD? No. This is one of those ones people typically have lots of questions about. He told me that when he felt frustrated, he would either cut himself or go out onto the streets and randomly beat someone up. Next, personality disorder. So in this one right here, what gender do we typically see with this diagnosis?
More often diagnosed in females.
Mm-hmm. Yeah, females. Linnell's smiling. Linnell's got a couple on her caseload. Constantly seeking attention, excessively emotional, dramatic, sexually provocative to gain attention. And I think we didn't talk about this in the BPD, but this is another one of those characteristics we actually see in the BPD too. Very highly sexually active. and just not safe at all. Speak dramatically with strong opinions, but few facts or details to support them, easily influenced by others, rapid changing emotions, excessive concerns with physical appearance, and thinks relationships with others are closer than they really are. I had one patient come in, and she actually told me that she was married to President Obama, and that Michelle was in the White House taking care of her kids. And I mean, she wasn't delusional. Of course, that's a delusion, but you know, but she was really, really interesting to work with. Very sweet lady. You otherwise wouldn't, you didn't know, not schizophrenia, you know, that you typically think of with a paranoid, but very, 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 she appeared very average. You know, not somebody that you could just look at and just tell. Some people you can look at, right? And you can just tell that, okay, something's wrong with them. You can look at them and pretty much start to, if you're anything like me, I'm always diagnosing people. Common schemas associated with this particular personality disorder include appearances are what matter the most. I must be noticed in order to survive. I must get what I want. And in order to get what I want, I must be the center of attention. Brings to mind anybody? Typically we can find people that you know, that you're working with, that you can sort of see some of these characteristics.
Donald Trump.
I wasn't really asking for an opinion. I was just think about it. Just think about it. So common defenses include regression in the reversion to an earlier stage of development, conversion, the expression of this conflict of a physical symptom. Some examples include blindness, deafness, paralysis, numbness. You'll see hysteria. Repression is the unconscious blocking of unacceptable thoughts, feelings, and impulses. The key to repression is that people do it unconsciously, so they often have very little control over it. Some of the common defenses here.
Can I ask you a question?
Yes.
Currently is the idea of, in the conversion description that you just gave, is there any connection between the perception of hysteria,
It's only a couple miles away.
hysteria and Freud's old perception that it was connected to sexual abuse? Is there any connection with that these days?
I don't know. I don't know if that's true or not. At least I haven't had the experience of that. Jim, what about you?
I don't know.
Yeah, that's interesting
Just
though.
curious.
Yeah. Yeah. Anybody else? A little bit dramatic, right? Some of the signs and symptoms of HPD include uncomfortable in situations in which he or she is not the center of attention. Interactions with others is often characterized by inappropriate, sexually seductive, or provocative behavior. Displays rapid shifting and shadow expression of emotions, and uses physical appearance to draw attention to themselves, and which I think is a lot. This is very close to what diagnosis is this very close to? Before I say it, what is it?
It's bipolar.
Bipolar? What did you say, Jim?
Borderline?
Yeah, very close, very close. Yeah, but you do see a lot of those diagnoses, a lot of these characteristics, I'm sorry, you can be found in bipolar patients, yeah. But very close to BPD. HPD and BPD, I mean, they're very close. Somebody had their hand up? Yes, ma'am.
What would be like the therapeutic approach when working with these clients? Do you kind of show just like,
Yeah, go ahead, Jim.
I'm gonna talk about that, about different interventions.
So here's an acronym that you can think of when you're working with somebody. So these are some of the things you can look for, okay? So I crave sin is the acronym. So I, inappropriate behavior. C, center of attention. R, relationships are closer than they really are. They appear to be closer than they really are. Appearance is more important than anything else in the world to me. Vulnerable to other suggestions, easily influenced. Emotional expressions are typically exaggerated. Shifting emotions, speaking in terms with lack of detail, stuff just flying out of their mouth without any support of those details. And novelty is craved. So I crave sin, and that's the acronym for when you're looking at somebody who has the HPD. One of our favorites, right? One of our favorites that we hear a whole lot about, narcissistic personality. So here are some of the things we look for when somebody is possibly narcissistic. So a belief that they're special and more important than anybody else, all right? Fantasies about power, success, and attractiveness. Failure to recognize others' needs and feelings. They lack that empathy. They have very poor social skills. An exaggeration of achievements and talents. Expectation of constant praise and admiration and arrogance. And I'm not talking about what your husband, because there's so many women in here today, not what your husband craves. I'm talking about rule of thumb is only when you can have these characteristics, right? And you can still be normal. You can have some of these and still be perfectly normal, not able to be classified or diagnosed with a DSM disorder. But the rule of thumb is only when these particular characteristics impede or interrupt your normal functioning, then that's when we consider it to be a disorder. Okay, so rule of thumb, you can have these particular characteristics and be perfectly fine. But when they impede or interrupt your normal functioning, that's when we talk about, okay, you probably need a diagnosis now, all right? And remember, we don't diagnose our spouses. We don't diagnose our significant others. We don't diagnose friends, okay? Unreasonable expectation of favors and advantages, often taking advantage of others, and an envy of others, or a belief that others are envy of you. Any questions? Yes, ma'am.
I know you spoke about the borderline personality disorder and histrionic as being primarily women.
Mm-hmm. And
with this. Is that the same for narcissistic disorder? Or?
no, it's not. She just wants me to touch on it. Good job. Thank you. And that's the reason why I start talking about husbands and spouses, because this particular diagnosis is most often found with who? Men. And don't call his name. So next slide here. Common schemas, okay? I'm more special than anyone else. I should only have to relate to people who are special like me. I must be admired. I deserve to have privilege. Other people don't deserve what I have. And their defenses include this idealization that trending to perceive another's individual as having more desirable qualities than he or she may actually have. The value of other people's achievements, belittling them, becoming hostile when confronted with these shortcomings. Any questions? And I see the wheels turning too. So, but that's what I want you to do though. If we talk about these, you can think about people like, oh wow, all right? Mm-hmm. So here is the acronym for when you're diagnosing somebody with a narcissistic personality disorder. A fame game. A, they need admiration and they require excessive amounts. It's so emotionally draining to live with somebody with this personality disorder, because you got to always tell them how good they are and all those different things. Lots and lots of praise and admiration for them. They fantasize about unlimited success. All they can ever talk about is when they make it big, or this next big win that they're going to get, and just how big things really are going to be. Arrogant, manipulative, envious of others, does not like to see other people achieve, and especially anywhere near them or more than they are achieving. This grandiose sense of importance associates with special people, always talking about how those name droppers, always dropping names, me first attitude, and that lack of empathy. I love me some me, right? If they could, they would only be in a relationship with themselves. Narcissism. If you can't love yourself, who can you love? So, aging clusters, I really want to talk about the aging clusters, but some research indicate that cluster B may improve. We talked about this a little bit over time, where many no longer meet the criteria of personality disorders, but BPD mood regulations comes more under their control as they have less of a need for the drama, all right? APD comes to terms that prison is for young people, and with aging disabilities due to reckless behavior, there are more medical issues. HPD no longer need to be constant centers of attention, and narcissists may be able to accept the aging process, but when they don't, they may submit to many plastic surgeries, drugs, and steroids to stay in shape. And in my mind, 3 from Hollywood just popped up. So those are some of the things that we talked about. Typically, there is an improvement, though. All right, I think it's again, when you see that comorbid disorder with other diagnoses attached to that personality disorder, then that's when you can see some of that. Jim.
Okay, we'll get that started. My avoidant traits are telling me to cut it short, but my OCPD is like, we gotta go on, we gotta move on. So, also, I just wanted to take this time to thank everybody for coming today, and everybody in San Bernardino for joining us. I also want to introduce some special guests. My wife, Lydiana, is right behind. She can tell you which personality disorders I have. And my good friend, Elizabeth Eustick. Elizabeth used to work with me with behavioral health, and she was a mentor for me when I was going through my licensing test, so please give her. And at the front table, Jennifer Kennedy is also at the U.S. Marine Corps base, and we work together on programs, and really appreciate you coming today. So cluster C, you might think of the C as cautious or overly cautious, avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So in the little illustrations, cluster C for avoidant, I won't go, no one likes me anyway. So they're basically telling themselves their cognitions as I'm not worthy, and that this is too much of a challenge, so it's very difficult for them to go places, although they want to have friendships, they want to be with other people. The dependent personality is, what do you think I should do? Okay, sure, yes, please, just don't go. And the obsessive compulsive personality disorder, if it's not on the list, then it don't exist, right? So the cluster C, if you think of these together. And again, I have some problems with obsessive compulsive personality disorder being in with avoidant and dependent. But avoidant is inhibited, they have an inferiority complex, social withdrawal, extremely shy. They'd rather avoid situations than to deal with situations, and have very low self-esteem. The dependent is very insecure, indecisive, clinginess, passivity. They require constant reassurance and fear of being alone. And the OCPD is very rigid, and they require order. That means more to them than anything. And they need rules and organization. They try to be perfectionists, exceedingly moral, and constantly productive, and to the point of being very rigid. So the avoidant is too sensitive to criticism or rejection. A lot of people think that avoidant personality disorder is actually on the continuum of social anxiety, social phobia. And it's really difficult to tell the two apart. Avoidant personality may be on the extreme level of social anxiety. One of the differences, if there are differences, it could be that for social anxiety disorder, it's kind of ego dystonic. They don't really feel like it's them. They feel like it's something that is a challenge with them, and if they could overcome it, then they could, improve their life and they could get better, but they don't really see it as them. Whereas people with avoidant personality, they see it as a flaw that's who they are. Basically that's a cognitive schema of them, that they are inferior and that they can't get along, or that they're not capable or competent. And they feel inadequate, inferior, unattractive. They avoid work activities that require interpersonal contact. Socially inhibited, timid, and isolated. Avoid new activities or meeting strangers. Extreme shyness in social situations and personal relationships. And fear disapproval. And they're very sensitive. So if you say something to someone who has an avoidant personality disorder, maybe criticize something they did at work or something that you didn't like, they take it to heart. I mean, it's really can be very devastating for them, whereas other people can accept it and they may be upset about it, but they can shake it off. But avoidant personality disorder people have a very difficult time shaking off criticism. So they avoid risk, avoid intimacy. They're very afraid of being embarrassed, especially in social situations, so they don't take chances, they don't take risks. They avoid social interactions. It's not like schizoid and schizotypal where they don't want social interactions. These people want social interactions, and they feel very bad that they don't have these close relationships, but they're so scared of having close relationships because they're scared of being hurt, rejected, or embarrassed. So they're preoccupied with negative perception of themselves. The common schemas: I must be liked in order to be accepted. I must not look foolish to others. I can't accept criticism. And isolation is better than being ridiculed or rejected. The dependent personality disorder has excessive dependence on others and feeling the need that they have to be taken care of. Submissive or clingy behavior toward others. If you think about it, think about a person in the ocean that can't swim. And whoever comes by who can swim, they're going to grab onto them. And they're going to hold on for dear life. And they basically, it's like a survival thing for them. There's such a deep schema belief system within themselves that they can't make it on their own, that they'll cling on to others for, like I say, for dear life. Fear of having to provide self-care or fend for themselves if they're left alone. Lack of self-confidence. Require excessive advice and reassurance from others. Difficulty starting or doing projects on their own. They just lack self-confidence. They have difficulty disagreeing with others. They fear disapproval. They can tolerate poor, abusive treatment because they feel like if they're left alone, they're not going to survive. So again, it's like sometimes for them, they may feel like it's better to accept being mistreated than being left alone. So can't confuse though. Sometimes in domestic violence situations, people may stay in situations that we don't think they should stay in. But what is the most dangerous time for someone in a domestic violence situation? When they want to leave, right? When they're trying to leave, that becomes very dangerous. So just because someone stays in a situation where they're being abused, it doesn't necessarily mean they have a dependent personality disorder, but many people have dependent personality disorders, are willing to stay in those type of situations because of fear that they can't do it on their own. And there's an urgent need to start a new relationship when a close one is ended. So if something happens to the relationship that they're in, they're going to cling on to the next person because, again, they never learned how to swim. So whoever can swim, whoever has a life jacket or whatever, they're going to grab a hold. And sometimes even before the relationship ends, if someone else comes along that seems to have more stability, more security, more safety, more support, they may cling on to the other person before, even before the other relationship ends. You might think, or at least I would think in the past, like a dependent personality disorder, you think they'd be very loyal to the person they're with. But it's not so much they're loyal to the person they're with, they're loyal to their own fears, basically, that they can't do it on their own. So they're willing to, grab a hold of somebody and hold on for dear life, even if it's not something that they enjoy or that there's problems in the relationship. So their common schemas: I can't function without the support of others. In any situation, if I make a decision, I'm probably wrong. I can't express anger or people will leave me. If I'm by myself, I won't survive. And basically, I can't be alone. That's the bottom line. So then we get to obsessive compulsive personality disorder people. These are people preoccupied with details, orderliness, and rules. They want perfection, and it can result in dysfunction and distress when perfection is not achieved. If they can't finish a project, if it can't be perfect, then they'll delay. They'll keep working on it, trying to make it perfect, but they can't ever make it perfect. So it's very difficult for them to have time management issues. They desire to be in control of people, tasks, and situations. Their inability to delegate tasks because they feel that they're the only ones that can do it right. So it's very difficult for them to ask somebody else to do something because they basically don't think anybody can do it as good as they can. They desire to be in control of people, tasks, and situations. They neglect friends and enjoyable activities. These are people that have a very difficult time taking vacations. And if they do go on a vacation, what do they bring with them? They bring their work. They have their laptop, they're in the motel room while their wife and kids are out on the beach, or if they're out on the beach, they're on the laptop. They're constantly thinking about work and doing work because to them, productivity means that's their self-esteem is built around productivity. Also, they have an inability to discard broken or worthless objects. Lydiana, don't say anything, but I kind of have that. But they're rigid and stubborn, inflexible about morality, ethics, or values. Basically, they believe in structure. So you might think of them, if in a religious sense, they're much more focused on, say, the Ten Commandments than the New Testament of love and forgiveness. So they're inflexible about morality. They're tight, miserly, control over budgeting and spending money. Basically, they're not going to lend money to other people. They're not going to buy somebody a meal or anything like that because to them, they feel like that's against their rules, and they are so rigid. These are people who, let's say they enter their son into Little League baseball, and if the kid doesn't catch the ball or strikes out, they're going to have the kid for hours, at a pitching booth or something. So they take the enjoyment out of doing something, some activity, and they make it into a chore. They make it into a lesson. You have to be perfect. You have to do this. You have to do that. So they can achieve. They can be very successful in jobs and business. There's been studies to show that many people that make it through law school and medical school have OCPD or some variation. So it can drive people to achieve, but it's at the expense of social relationships. And it's basically, in their frame of mind, it's my way or the highway type of thing. So if you don't go along with what I think is right, then you have to get out. Common schemas, one must follow the rules to the T. They focus on details. The better job that you do, the better person you are. So their sense of self-worth is wrapped around how they achieve at work. They're workaholic. Emotions must be controlled at all times. Keep the stiff upper lip. Never discard anything because it may be of value someday. It may come back in vogue, or it may be worth something if you can keep it for 30 or 40 years. And their theme song, I ain't got nobody that I can depend on. So these are people that, again, can be very successful, but not necessarily successful in social relationships. Leisure activity is minimal. They have an organizational focus. Work and productivity predominate their whole life. They have miserly spending habits, even though they got the money to spend. Inflexible around morals and values, very rigid and stubborn. And the task completion is impaired by perfectionism. It's hard for them to score. So obsessive compulsive personality disorder is not the same thing as obsessive compulsive disorder, even though they have very similar names. And there's some similarities, but OCD are people that ruminate about different things, and they may have a phobia about dirt. They're going to be washing their hands 20, 30 times a day, or they're checking the door to make sure it was locked 20, 30 times a day. They become very obsessive, and it can be very debilitating, OCD, where again, OCPD may be very successful in their line of work.